Well, Happy New Year, everyone, and welcome to 2022 and the launch of Season 5 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. This new season of the Healthy Skeptic, I am going to experiment with a couple different formats. I'm going to try to mix up some of the interviews I do on topics with news summaries and other formats, and today's actually a good example of that because with the latest surge of Omicron, I thought it would be a good time for us to get a good practical update on what's going on. And my guest is Dr. Pieter Cohen. I've had him in the past on a couple episodes on dietary supplements and on COVID-19. Pieter is the lead author of the outpatient treatment for COVID-19 chapter in Up to Date, which is the main medical textbook. So someone very knowledgeable about this topic. He also runs a COVID-19 clinic at the Cambridge Health Alliance. And we are going to cover all those nuts and bolts, practical tips about what's new. Pieter's going to give us his take on how the Omicron strain may be acting differently compared to prior strains of COVID-19, what we should know about Paxlovid, this new antiviral pill that was recently authorized by the Food and Drug Administration. Pieter's also going to give his take on the CDC's new isolation guidelines that were shortened to 5 days for patients with recent infections. One caveat on this, shortly after I recorded this discussion with Pieter, the CDC issued a new recommendation, which is actually very much what Pieter and I talked about adding a recommended antigen test before patients are released from isolation after an infection. So apropos to our discussion. And Pieter's also going to talk about antigen tests, what they can and can't tell us. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts or on YouTube. Pass it along to friends, family, and others who might be interested. So with that, let's jump into our interview with Dr. Pieter Cohen from the Cambridge Health Alliance. All right, well, welcome back to the Healthy Skeptic MD, Dr. Pieter Cohen from the Cambridge Health Alliance.
Mike, it's so great to be back.
Well, we have a lot to cover. We're in the midst, unfortunately, of another surge of this pandemic, and I thought you'd be a great person to bring in. And you just put out another great video on updates that I'll link to for anyone interested. But I sort of wanted to go through a rapid-fire list of questions that are coming up all the time that maybe you could help some of our lay audience better understand. So let's jump right in. The first is with Omicron. There's a lot of hope that this strain is going to be a little bit less virulent than previous strains, that we're not going to have quite the hospitalizations. Part of that may also be due to greater immunity. More people have vaccines and prior infections. And although we'll have a lot of cases, it may not lead to the surge of hospitalizations and deaths that we've seen in the past with prior surges. What have you seen in your COVID clinic so far?
Well, it's been really interesting, Mike. First off, the amount of spread and the amount of people simultaneously contracting the Omicron variant or SARS-CoV-2, the virus, because we don't really do variant checks, on our patients. But right here in Boston, we're seeing about 82% of all cases are due to Omicron. And what we really have seen is that it's spreading dramatically faster. More people are simultaneously ill with it than ever before. There's good news and bad news. That's the bad news, is that it's absolutely everywhere. The vaccine does not prevent it, probably decreases transmission a bit, but you can certainly get it if you've been vaccinated. You can certainly get it if you've had another variant in the past. But what we are seeing, our personal experience, is that it's a milder illness in general. Now, unfortunately, that in general is really the key, because with so many cases, that still means we have a lot of sick people, a lot of people heading to the emergency department, a lot of people requiring hospitalization. But fortunately, it's a much milder illness in general than the earlier variants.
One of the thinkings there, right, is that it tends to stay more in the upper respiratory tract and be less likely, it still can, but less likely to go into the lungs and cause a true pneumonia, as I understand it.
Right, that's right. That's our understanding too here. And one thing that we find is that some of the symptoms might be slightly different, actually. In the first wave, we saw that sore throat, for example, like a bad sore throat or a sore throat like a strep was not something that we commonly saw. Occasionally we saw it. Now it's more common now we see without Omicron. So exactly, Mike, it's these upper respiratory symptoms, the stuffiness, the nasal congestion, the sinuses being blocked up, the sore throat. These are the kind of common symptoms that we're seeing with Omicron.
So you mentioned the vaccines, Peter, and we want to get this message exactly right. So let me try and state my understanding, and you tell me if I'm misunderstanding it. The vaccines are incredibly, incredibly important, both the primary series and the boosters, for preventing people from getting sick and getting hospitalized and dying. So absolutely everyone should be getting vaccines, but they do seem less effective at blocking transmission and blocking those initial infections. Is that a fair assessment?
Perfect. The really important thing here is for us to unpack two separate issues. One question is, how dangerous is a COVID infection going to be for you if you contract the virus? And the second question is, are you going to contract it? And what we really care about is that first question. We really care about the fact that we all want to make sure that if we do contract the virus, that it's not going to be a serious infection, that we don't need to go and see a doctor. We don't need to go to the emergency room. We're not going to need oxygen or hospitalization. That's the most important question. The vaccines consistently show the best evidence for preventing that being hospitalized or dying from the coronavirus is from getting vaccinated. And that holds up with Omicron and all the other variants. Unfortunately, in terms of the second question, transmission, Omicron has a way of easily evading the sort of immunity that's created by the vaccine, so it doesn't work as well. But it's still extremely protective of serious disease. So there's no question in my mind, it doesn't change one iota of my opinion that the most important and the first thing one should do, not just to protect yourself, but to protect your families, your loved ones, coworkers, and the community, is to get fully vaccinated.
Right, and I've heard that the vaccine is sort of like converting a COVID infection from a serious life-threatening illness to maybe more of a common cold or flu. So, Pete, compared to prior flares of the pandemic, we have an important new tool now. There's a new FDA-authorized medication called Paxlovid that just became available. Can you tell us a little bit about it and which patients should consider getting it?
Sure. Well, first of all, I think it's most important to say off the bat that for the next few weeks, maybe even the next few months, access to these pills are going to be extremely limited. But that means that for right now, we should be using this for our most highest risk patients. So, but let's now talk about what this is, because in a few months, it's going to help us revolutionize the treatment of COVID. Basically, the pill is two different medications, and at the core is a mechanism to stop viral replication. So it basically gets in there in a way that jams the machinery, the engine really, of the novel coronavirus. And this, by jamming the machinery, what's really exciting about this type of medication is that it's machinery that we don't have in our normal cells. So it's something that the virus has, we don't have, and it jams the system, stops replication. That's the idea. It's very exciting because on initial study, which seems to be robust, although I need to let you know that we haven't, the full report has not been released to the public. We just have summaries. The FDA has received the full report, but it looks very promising. Thousands of patients randomized, dramatic reduction in hospitalizations and deaths for people that are started on these pills early enough.
And I think it's fair to say, Peter, you and I are on the conservative side with new medications. We tend to have a cautious approach. This is one of those situations where we're certainly encouraged. With that said, do you think everybody with a mild COVID infection should get it?
No, especially right now, Mike. I really think we should be limiting this to the very highest risk people. But the NIH has set up a system, a tier system, to identify if you only have a few of these dosages, who should be getting it. And I'll just tell you about the top tier. And that the top tier are the ones we probably don't even have enough to cover the top tier right now in every state. But basically, the top tier would be someone who's at very high risk for serious disease from COVID and is either not vaccinated or they have profound immunodeficiency such that the vaccine isn't thought to have created real immunity protection from serious illness. Those are the only people right now that I'd recommend getting this new combination pill because of limited supplies. Later, we can kind of expand that to more people.
And also, I think as you get to healthier folks with milder illness, the risk benefits become a little more challenging. So I think both for the supply issue to make sure it gets to the people who need it most, and until we have a little more data, it really does seem to be the highest risk people who we should prioritize it for.
Right, Mike, I completely agree with you. That's an important point. Let's imagine, flash forward 3 months from now, 4 months from now, we have plenty. Then I think it's going to be really important to make the point that people at low risk of needing to be hospitalized do not need to take this pill. And because it's a brand new pill, we're going to slowly understand more about its potential side effects and how it interacts with other viruses and people's kidney function and other drugs, you name it. That's going to take a lot of time. So unless someone has a high risk of being hospitalized, I don't recommend this pill or any sort of treatment. It's really for the same types of patients who we in the past recommend monoclonal antibodies. The antibodies being infused into the bloodstream that combat the virus.
And in terms of the monoclonal antibodies, Pieter, that and also remdesivir, those were treatments that were talked a lot about earlier in the pandemic. Do they still have a role with this new medication, Paxlovid?
They will have a role. They could have a role, actually. We really need to understand this better because they work on using different mechanisms to stop the virus. One's beefing up the immune system. That's the monoclonal antibody. Then there's the jamming, the viral replication, which is the new pills, and then remdesivir similarly interferes with the virus itself. So it's possible, and we're going to need more studies about this, about whether or not we can combine these different regimens, but it's very possible. You can imagine a situation where for our very highest risk patients, those, for example, who have gotten vaccines, but there's no sense that they have any immunity to the virus due to profound immunodeficiency. What you could imagine in the future when we had plenty of supplies would be use a monoclonal antibody plus the pill. It's possible. But for most people, it's going to be choosing either the pill will be able to easily replace the monoclonals.
Yeah, so it seems like there's a lot of moving parts. The good news is there are several options now. We're still trying to put all the puzzle pieces together, which patients need which. But the key take-home message is really the highest risk, the immunocompromised, who should consider talk with their doctor about getting one of those treatments. And Paxlovid in particular, I think there's a lot of appropriate enthusiasm for. All right, so I want to shift to the CDC isolation guidelines for someone who's been infected with COVID-19. The CDC made a controversial change. I have an opinion on this. I'm really curious what your take on it. They shortened the isolation period from 10 days down to 5 days. Do you think that was an evidence-based decision, and do you think it was the right decision by the CDC?
That's controversial, and I wouldn't say that's not my practice now, despite the CDC. I do really like, there's a part of this here that I really like, which is let's stop being overly conservative, which the 10-day isolation was. And 10-day isolation is really excessive because most of the time that one is infectious and can pass it to someone else during a COVID illness is during those first few days, usually the first 5 days of infection or less, 2 or 3 days. And what's really challenging is that it's really a day or two before you even have symptoms. And that's when you can also pass to other people. That's the challenge of the virus. But despite that, the CDC was having people isolate for 10 days to be very conservative. And I like the idea of opening that up and saying, hey, maybe everyone doesn't need to be isolated for 10 days. That's good thinking. But I would have liked to see this more gradual. And I would have liked it to drop it down to 7 days first and see how we all did with that. Alternatively, if we wanted to drop it down as little as 5 days, then I would say let's do something like a rapid antigen test at 5 days to make sure that's negative before people return. So that's my personal practice. It's what I advise my patients to do. It's what we've done here in the family, is that we'll isolate at day 5, check a rapid, and then decide based on that. If the rapid's positive, then still isolated, quarantined for more days until either 10 days are up, or if you have enough tests to check them, an rapid antigen test has become negative.
Yeah, so it sounds like we actually are fairly close in our perspective on this one. I do applaud the CDC for trying to shorten that 10-day period. I think that was excessive. I think the data is that the vast majority of spread is in the 48 hours before someone develops symptoms up to the first 2 to 3 days. I think 5 days may be a little bit too soon. And actually what I think I would have favored is to put that rapid antigen test at the end of the 5 days. If that's negative, it is very likely that someone's no longer contagious. And the CDC's even been discussing adding that rapid test at the end of the 5-day period. So
I completely agree with you. We have why I probably would have done 7 days is the logistics of it. We just don't have. I know that the administration is planning on sending out 500 million rapid antigen tests for free, and we have some availability, but it's very hard for us to get our hands on rapid antigen tests at this time. So from a practical perspective, I don't think that's. It's really a tough situation right now.
Well, what I've been telling my patients is if you're feeling better after 5 days of illness, you're not having fevers at least 24 hours, get a rapid antigen test at the end of 5 days if you can. If that's negative, you should feel pretty good returning to society. And if you can't get a rapid antigen test, then maybe you do wait an extra couple days.
Yeah, and I think it's important for us to say too, Mike, that we still want for those for the full 10 days, so another 5 days, to make sure that this is a situation that anytime you're in enclosed quarters with other people, be it your family or outside or at work, make sure you're wearing a mask.
That's a great point. So, you clear that 5 days doesn't mean go to a big sports game with a lot of people around you. That's a good time to still wear a mask, be a little cautious for the next 5 days, because there may be some residual contagiousness going on. So, Peter, I wanted to ask a couple more questions. The next one's about long COVID. You've actually been doing a lot of work with patients with long COVID at the Cambridge Health Alliance COVID clinic. What insights have you gained about this from your experience working with these patients?
Yeah, well, I think the biggest misunderstanding or narrative that I'm disturbed by hearing so often in the mainstream media is, and also from some groups that advocate for patients with long COVID, is that there's some sort of hard and fast division between psychiatric illness and other types of illnesses. Let's say someone has a heart attack and they're hospitalized, and they come out of the hospital and their heart disease is well controlled with aspirin and cholesterol medications. Their blood pressure is well controlled. But then they have typical symptoms of major depression. They can't get out of bed. They have lack of motivation. They have no appetite. It's hard to concentrate and feeling hopeless. Now, we don't get ourselves tied up in a pretzel trying to figure out if something about having the heart attack, if it was like some lack of oxygen to the heart or some enzymes that are released in the body that damaged the brain and caused major depressive disorder, or if it's entirely hormonal neurotransmitter imbalances in the brain.
And we know there's a mind-body connection, that the physical illness affects mental illness. That's very well established.
Absolutely. So we have a situation here where it doesn't matter if it was due to some lack of oxygen briefly in the hospital, if it was due to the anxiety and stress of being in the hospital for the heart attack, or thinking one might die from the heart attack. It doesn't really matter what triggered it or why someone has major depressive disorder, but it also doesn't make it less real if the symptoms are related to actual lack of oxygen or due to being terrified of having the heart attack. So what I hear a lot actually when it comes to long COVID is sort of this division. Is it just a imbalance in the brain based on the experience of living through the pandemic with the infection, or is it that the virus got into the brain and did this damage? That's not a very fruitful route to go. I think the point is people are suffering. We need to absolutely recognize that and then treat effectively. So I guess that's my one take home, Mike, is I wish we could get away from this, whether or not the virus is actually still in the brain or replicating in the brain or did direct damage to nerve cells. That's really not the question. That's most important to patients.
And what I would add to that, and I think you've alluded to this in the past, the critique that doctors maybe are not taking it seriously because they think there's a psychological component to it. I take psychological conditions like PTSD and depression very seriously. I treat it in the same way I would any other mental illness. And I think that's the way you do take it seriously and treat it appropriately because, if there is a psychological component to it, the treatment is different. It's not a pill. It's not an antiviral medication. It's some of the therapy techniques. Maybe it's an antidepressant. There's it really has treatment implications.
Right. I think you'd have to go back, 40, 50 years, Mike, before when doctors were not taking PTSD, depression, generalized anxiety disorder seriously as a very serious illnesses that require timely and excellent care. And I think that we need to get away from talking about whether or not this is, the mechanism and focus on the illness.
Okay, Peter, I want to end with two very pragmatic questions. The first is your health, relatively healthy middle-aged person, you develop COVID. What should you do? What should be going through your mind?
So you're healthy and you're middle-aged. That's great news because especially if you're vaccinated, you're going to do really well. So what should be going through your mind is getting yourself from in a position where you're not spreading to anyone else. That's really the key. And of course, it's impossible to have known, days before you develop the illness that or you're positive that you had it. So just make sure you're careful communicating that with everyone who you spend time with. If you start having symptoms, you start having trouble breathing, you start feeling dizzy, especially if you're having symptoms predominantly or they're worsening when you're walking around, going up a flight of stairs, walking in the house, particularly, after you've had the virus for a few days. So you're in days 4 through 8 of illness. Those are good times important to call your doctor to say, hey, I have COVID and I'm starting to have these new symptoms several days into the illness. Let them know. But otherwise, I would sit tight and make sure that you're not spreading it to other people.
Yeah, and these are a lot of the same common sense advice, the same, alarm signs that you would look for if you had a bad flu, when to call the doctor, the same things that are going to apply here as well.
Absolutely.
So last question, Peter, is there anything in your experience working with in the COVID clinic that you wish more people understood about this disease?
Well, I think that knowledge is really high, and that's super. There's a lot of engagement, so much learning. I would say one of the more common sort of confusions right now is that because we're dealing in a situation where there's more home antigen tests being done than ever before. So I think the most important thing is for people to understand the following. If you have viral symptoms, if you have those upper respiratory tract infection symptoms, you have a new runny nose, your sinuses are congested, you have a little fever, sore throat, you go and do that rapid antigen test and it's normal. Here's the key. You still need to presume right now in the middle of the Omicron wave that you have COVID. That test actually does not help you tell you that you don't have COVID. It's a crazy thing to try to understand. But it's basically, if you do the test, it's helpful if it's positive because that tells you definitely do have COVID. But the negative test doesn't tell you which way. Maybe you have COVID, maybe you don't. It's still a total mystery. So you just need to assume that you might as well just pretend you didn't do the test, and you can repeat a test tomorrow, or you can go and find a PCR test, or you can simply isolate for the 5 days. Those are really the options.
And the truth is, whether it's the flu or COVID, you still want to be at home isolating and taking it easy, and you don't want to spread whatever it is. I think it's really important for everyone to keep in mind that these antigen tests especially are not perfect. They're very helpful because you get a rapid answer, especially if it's positive. That can be very helpful. But if it is negative, it's just one piece of information. If your symptoms are otherwise consistent with COVID, you have a viral illness right now, given the current state of the world in this pandemic, you're going to want to stay home and isolate.
Precisely. And then just let me say that it's different if you have no symptoms. So if you're in the situation where the opposite situation is you have no symptoms and no known contact with anyone who had the virus or has been sick. You do a rapid test. If it's negative, then you should be very comfortable that you don't have COVID that day.
I think that's a great point. And I think that's another one of the great uses of the antigen test. Say you're going to be visiting your grandmother or going to a holiday gathering. You don't have any symptoms, but you want to provide that extra level of reassurance. I think that's a great use of the antigen test just to make sure that you're another piece of evidence that you're not carrying an asymptomatic infection.
I completely agree.
Well, Pieter, thank you so much for joining today. I know a lot of people are struggling with these questions, and I think it was very helpful in breaking it down for a lay audience. Thanks for joining us, and I'm sure we look forward to having you back again soon.